Hello everyone. Today we're going to be talking about our heart failure exacerbations and how we actually classify patients and what treatments we will use for these patients that are in heart failure exacerbation, come in to our hospital or clinic, and how we would characterize those, things of that nature. We'll start by going over with the KILLIP classifications, and if you remember, the best way to do that is put our patients into 4 quadrants. So we just draw a little line here, and we have one which we want ideally all of our patients to be in, and that is our warm and dry. And then we can have a second class where patients come in and they could be warm, but they would be wet instead of dry in this class. Then we come to our class 3, and they are cold and dry. And this is really kind of a unique place for our heart failure patients, and we'll talk a little bit about why in just a minute. And then our final classification, which is where we really want to try and keep our heart failure patients out of, is our class 4. And this is going to be the most common that you see that might come in with cardiogenic shock and things like that. So this is going to be our cold and wet. So what do these things mean? So let's take a second and dissect what that means. So if a patient is actually warm, so we know a patient's warm, we know that that equals that they are perfusing well. So that means that they're getting blood to their kidneys, liver, their extremities. They'll be nice, warm to the touch. Now, knowing that, what do you think the difference between cold and dry between wet and dry might be? So if we think about it, dry means essentially that we don't have any volume up or overload. So this would be no extra volume on board. So ideally, we want all of our heart failure patients to be perfusing all of their organs and come in and not have any of their extra fluid on board. So those are our patients, like we said, that are in the subset 1. And so for those, we can actually take another step and put the Forrester hemodynamic plot over this to better understand and give us lab markers to really see where these patients might be. So what might be some markers, especially when we get right heart cath numbers, that would give us these dynamics of being warm or wet and cold and dry and things like that? So how we assess if the patient has volume on or not is we actually do something, and it's called the pulmonary capillary wedge pressure. And this kind of gives us the volume that would be in the left atrium. It's a surrogate marker for that, and so that helps us assess volume. And from class, maybe you remember what these markers are. So if the patient is dry, they're going to have, so it'd be in class 1 or class 3, dry, so they'll have a pulmonary capillary wedge pressure of less than 18. Now on the other side, if they have volume up and are on that need diuresis or something like that, they would have a pulmonary capillary wedge pressure of, you probably guessed it, greater than 18 on the other side, right? So again, marker of fluid status. Now perfusion, how could we assess that? Well, we can get, you remember the cardiac output, or index is the primary marker that we use for the Forrester type plot. So those that are perfusing well, right? So it's going to be the opposite. Perfusion is going to be our cardiac index, and that's going to mark how well blood is going to the body. So our perfusion, exactly. So for a patient that's warm, what might you think a normal cardiac index might be? It should be greater than 2.2. Now somebody who's cold, not perfusing, might have kind of those cold hands, cold extremities. They're going to be the opposite. Their cardiac index is going to be a little on the lower side, and they're going to be less than their 2.2. So what does this mean as a pharmacist for us? What are we going to do for each of these patients when it happens? Well, let's take a look here. So if somebody is warm and dry, so we've got class 1, there's probably actually not a lot for us to do other than we're going to optimize their oral regimen. So what kind of things would we do for that? We're going to increase their beta blocker, their ACE inhibitor. We're going to make sure that their diuretics are at an optimal dose and really get them to prevent them from moving into 2, 3, or 4, anything like that. So what do we do for our patients in 2? Then if we do 1, we're going to optimize their oral regimen. What are we going to do for our patients in class 2? Well, they're perfusing well, so we don't have to worry about increasing blood flow anywhere in the body. So what we have to do is work on this wet. And we do that basically by adding diuresis to the patient or increasing what they're currently on, right? So either increasing or giving IV loop diuretics or giving an extra dose that day of PO, or adding our sequential blockades like metolazone. Anything like that can be done to help achieve this as well. Then we move over, do a quick on class 3. Now why I said class 3 is a bit of a struggle is because if you think about it, most patients when they have an exacerbation of heart failure, right, they have volume up, so they fall into this 2 or 4 most often. So these patients are often challenging because they don't have any extra fluid to get off, but they're still, something's going on and they're not perfusing, their heart may not be working enough to get the blood all over to their body. So what often happens is these patients are often dehydrated, and so for our class 3 patients, something we might want to consider is to give a small amount of fluids, actually. So we might try to fluid challenge them, get their intravascular space up and see if that actually helps the perfusion of the body. If that doesn't work, then we might go on to something like anatropes and things like that of that nature. But that's going to be our main course. Now our final class, where a lot of patients come in, is actually going to be our class 4 patients. And that's probably where you guys have heard the most already, is that our patients are going to be cold and wet. So what do we do for our patients that are cold and wet? Well, they're wet, so they're probably actually going to need diuresis. You've probably figured that out from just our class 2. But this also occurs when patients aren't perfusing, so they might have hypotension, low blood pressure, things like that nature, so we have to consider everything. So sometimes we break this down as to see how well the patients are perfusing. So they might have a systolic blood pressure greater than 90, or they could have one that's less than 90. And this is going to impact potentially our therapies and what we do. So if a patient has systolic blood pressure greater than 90, something we might try first, we're definitely probably going to hit them with our diuresis first. So we're going to go there first because they've got volume to give and they have a good enough blood pressure to do it. And other things we might do then are vasodilators. Does anybody happen to remember what those might be, thinking about that? So those would be like our nitroglycerin, nitroprusside, nitroside, are going to be vasodilators. And then after that, if the patient still needs a little bit more, we could also use an inotrope to give our heart that extra squeeze and pump to go through. So now, but if you think, so this is when they have good blood pressure. So if we move over to when the patient has a systolic blood pressure of less than 90, it may not be able to support that. Thinking through what might be a good thing to start off with. Well, you're probably actually going to start off more with an inotrope, because we're going to try and squeeze and create more going throughout the body and start there. At the same time, we're probably also going to add our diuresis because we have so much extra volume to give, and that's where we want to start. And then finally, if possible, we'll add a vasodilator on if need be at the end, but remember, using caution, vasodilators open it up and it causes a class hypotension effect. So that's why we use it lower. Another important thing about our inotropes is they're going to be our milrinone, dobutamine, and dopamine. And so for those, we need to make sure that a lot of, especially with dobutamine and milrinone, they also vasodilate, and we have to watch for hypotension and things of that nature. So this is a quick review of the subsets of heart failure, and especially in exacerbations. And stay tuned for the next one about specific agents and dosing. Thank you.